Our third speaker today is Dr. Sylvia Formenti. She is the chairman of radiation oncology at the New York University Langone Medical Center, the associate director of clinical research, and the co-leader of the breast cancer research program at NYU Cancer Institute, as well as an author of numerous scientific and scholarly articles. She completed her medical training at the Università degli Studi di Milano in Milan, Italy. She did a residency training in radiation oncology at the University of Southern California. She'll be discussing local therapies for breast cancer.
Thank you so much, and I do realize that I am the one left between you and an interesting debate, I like to think, and eventually your evening. So I hope I will provide you with interesting information, and I'll try to stay as brief as I can. And so I have conflict of interest. I get salary from grants, and also I participate in a speaker bureau from Varian that makes radiation machines, as well as Bristol Myers Squibb. But my conflict of interest will not be, hopefully I will stay away from any of this conflict of interest during my presentations. So, you know, at least in my own career in the United States, we've seen a huge change between the 90s and today that almost parallel the extent of progress that occurred between the 70s and the 90s, where really a group of outstanding investigators led in Europe by Umberto Veronesi, that was a professor when I trained in medical oncology in Europe, and Gianni Bonadonna, and in the United States were paralleled by Bernie Fisher and other group of investigators that really demonstrated, modified the management of breast cancer, and the previous speakers have already alluded to it. But then the question is, what was left in terms of local regional control and treating locally the breast, not systemically in terms of chemotherapy or hormonal therapy? What we were left, our generation, to challenge. And pretty much the idea was, from a radiation point of view, since already the equivalence of breast preservation to mastectomy had been established, the idea was to reduce the number of fractions, so maybe make it more user-friendly for patients to come to the radiation unit. Originally it was 30 times or sometimes 35 times, to reduce it, to make it fewer times with the same efficacy, and also start worrying about avoiding normal tissue close or in the field of radiation because of late effect of radiation. Unfortunately, radiotherapy, while very effective, and I'll show you the effective the evidence in that direction in a minute, brings late effects of toxicity to normal tissue that cannot be undone. So why is so important to focus on optimizing radiotherapy? Even after mastectomy, and this is again introduced by Cliff, a result of a meta-analysis conducted with the help of the group in Oxford that really has a lot of experience in reviewing all very, very large data sets. So here I'm showing you that the curves that of women who have undergone mastectomy and originally either had node negative or node positive disease. And we knew already that radiotherapy will change the risk of recurring in the breast and reduce it drastically. Here you can see a big reduction between the node negative and even bigger in terms of the node positive. But what came out in this large overview that was published in 2006 is that it has an impact on mortality as well. So somehow the authors of this review concluded that every 4 local recurrences that you could avoid by adding radiotherapy, you could spare 1 death to breast cancer over the following 15 years. So an impact on survival that was derived by the local control. And more recently, this was being shown also for post-lumpectomy cases, again, even more clearly, an effect on survival. So the gain in local control does reflect on survival. And interestingly, because the risk is, mortality is even higher, of course, in node-positive patients, you see a significant difference in node-positive patients. I just want to stress the size of this difference because sometimes it gets underestimated, and it's very difficult for me as a radiation oncology to witness maybe a young patient, some kind of falling through the cracks and having breast conservation, and then maybe she gets chemotherapy, but for whatever reason she never gets to receive radiotherapy because either she has a bias toward it, or she's concerned, or somehow doesn't end up finding the time or the resources or the access to radiotherapy. And we better understand that it's not only exposing her to more risk of recurring in the breast, which to a certain extent could be salvaged, maybe with a mastectomy when she recurs, but we may also prevent her from deriving a benefit on survival. And just for comparison, I want to show you, here is from another meta-analysis from the same group, the effect on survival in node-positive patients of adding anthracycline-based regimen, which is a good kind of classical chemotherapy, to no chemotherapy. As you can see, the size, this is at 10 years, this is at 15 years, but the size of effect on survival is quite considerable and comparable to that of adding chemotherapy in similar patients. So we kind of got intrigued by this effect of radiotherapy on survival and started thinking that maybe, so traditionally the idea was, if the tumor is local and you remove it with surgery and you add the radiotherapy, you somehow take away the source of cells that would have spread more and gone to other organs. Well, it turns out, and this we knew 30 years ago, 40 years ago, that breast cancer, particularly node-positive breast cancer, is already in micrometastasis and presentation. If you do bone marrow biopsies in women, particularly premenopausal women with positive lymph nodes, you will see little nests of breast cancer cells already there. So the idea that what we do locally may stop this shedding of metastasis is probably unrealistic. So you have to explain in a little bit different way why would radiotherapy have an impact on the survival of patients. And when this data came out of both meta-analysis, after the first meta-analysis, together with an immunologist at NYU, we started asking the question of whether maybe is more than just local control, that radiotherapy, by having an effect on the residual tumor cells, may do more. And we introduced this concept that, in fact, it may have an impact on the immune recognition of the tumor. I'm going to talk about it in a minute. But before we did so, others had introduced the concept that after surgery, you have this wound, this inflamed wound, because the surgical effect of removing the tumor induces that. And at least in the subset of patients, there may be a signature, a genetic signature in that wound that predisposes patients to recurrence and spread, and metastatic spread. And this is a nice study that came from the the Netherlands Cancer Institute, which is the equivalent of the NCI in the Netherlands. And they somehow did a very profound genetic study of the tumors of in the patient they studied. And initially on a training set and then in a validation set, which is a system for validating genomics. And they looked at the signature that was associated with the response to a wound. So the kind of genes that get overexpressed when you induce a surgical wound, as well as a profile that is associated with less oxygen. It turns out that when tumors grow, they tend to also acquire capacity to survive in the absence of oxygen, hypoxia. And then they tried to understand whether they could separate, if they follow patients long enough, could separate based on this genomic profile the ones who would recur and the ones that wouldn't. And true enough, both in the training set and the validation set, they were able to show that just based on a series of genes associated with how people repair a wound, you could predict the patients more likely to recur from the patients that had much lower 6 and 5% risk of recurrence. So maybe something associated both with the genetic of the patients and the type of tumor they have, maybe the crosstalk between the genetics and the type of tumor, in response to a surgery, predispose women to a local recurrence. So that's something that to keep in mind. Another group did a more sophisticated study. They took fluid from the surgical cavity, and then they used that fluid to grow cell lines in the lab. And they just, instead of feeding the cell lines with the typical fluid that we put on the cell lines, they fed it with this fluid coming from the surgical cavity of patients. And compare the fluid after a localized radiotherapy done during the surgical session. So there is a way, and I'm going to show you in a minute, of giving radiotherapy during surgery. They use the fluid that got irradiated, and they use the fluid that didn't get irradiated. And true enough, they found that the irradiated, which was from the target study, versus the untreated one, had much less likelihood to induce colonies of this cell line called MCSF7 in matrigel, which is a material to sustain the colonies. And also the invasion capacity, when you grow the cell line with a fluid irradiated, went down. So there is something radiation does to the capacity to spread, to the capacity to form colonies, and to the capacity to invade that is positive, so is against the tumor. We came up, and I was alluding to it a few minutes ago, with a different hypothesis, whereby, sorry for the graphic, this is not Leonardo, but it's one of my postdoc trying to portray a tumor cell. This tumor cell is sitting there in the microenvironment, very schematic here, and has antigens, and it turns out that in nature, when tumors occur, they have escaped the control of the immune system. But despite the fact that now they're capable to grow, so the immune system has not rejected them, they are constant. There is a constant crosstalk. It's a very plastic situation with a lot of immune cells permeating the tumor mass, and this is portrayed as the dendritic cells, which is a cell capable to pick up pieces of tumor and somehow explain the tumor to the immune system. And the idea is that when you give radiation, and maybe when you give concurrent chemotherapy and radiation, and certainly when you give certain types of chemotherapy as well, what you do, you definitely kill the tumor cells and release antigens. There is now evidence that there are very specific radiation-induced antigens that were not there before you gave the radiation. And maybe you're capable then to re-instruct these patrolling dendritic cells to teach them to mount an immune response. And now, before they were hanging around but not really understanding who are the bad guys, and now they are understanding who are the bad guys. And if you're lucky, in a subset of patients, they will kill the tumor locally, but also, because that's a characteristic of the immune system, use the tumor as a vaccine now, and in fact immunize the patient also against the metastasis. And maybe this is an alignment between people who have a predisposition, a certain capacity to be a little bit better at reading when you break down the tumor. Maybe it's a capacity of certain tumors being more immunogenic. There is some evidence that triple-negative tumors may be more immunogenic. And in any event, if this happens, it could explain that difference you see in survival after you irradiate the patients. So we introduced that abundantly, and we have looked into mice to reproduce this system and been somehow successful, but I'm not going to spend a lot of time on this. So going back to radiotherapy and the challenges that we are confronted with. So the very basic one is to decide how to, we're talking about a lot of precision medicine or personalized medicine and how to tailor oncology to the specific patient and the specific characteristic of the tumor. Well, we're trying to do the same for radiotherapy as well. In my opinion, not sufficiently. We could do it even more. But definitely a very important thing is to decide whether the same target is necessary. You heard from the speakers before that, for instance, if you do less surgery, maybe you have to compensate with radiotherapy and vice versa. So defining the targets is really important. Addressing, when you use a radiation beam, you have to take into consideration that, for instance, respiratory motion, the chest moving up and down, may move your target. So you certainly don't want to shoot the beam into the lung. If you can avoid it, you want to control that excursion. And of course, deciding what is the best technology to deliver the treatment. So defining the targets is whether you treat the whole breast, part of the breast, and whether you treat the lymph nodes and all the lymph nodes as well. So unfortunately, the bad news is that there is a big variability even among experts in defining the targets. This is an interesting study I often show because there were probably 10 or 12 of the most famous experts in radiotherapy of breast cancer, who volunteered to to lend their expertise to contour the breast and the tumor cavity. And as you can see, the structure overlap among these 12 people was as low as 10%, and with standard deviation up to 60%. So even when you have experts, you may miss the correct definition of what is the target tissue to treat. An enormous amount of literature, there are pages of references to try to define, from a radiation oncology point of view, what is exactly the target of the tumor cavity. So first of all, there is a big issue that the tumor cavity changes with time. So if you give 6 weeks of radiotherapy, over 6 weeks things can change drastically. And here is a study again from Europe showing how over time, the size of the seroma cavities where the surgery was done is modified. So if you treat here, you have a different volume than if you treat here or if you treat here. And then, of course, there is interfraction and intrafraction, so whether during the fraction of radiotherapy there is movement, and whether the patient sets up in the same position from one time to another. And all of this is particularly relevant if your target is limited. If you're treating the entire breast, it's probably less relevant, but if you're treating just the tumor cavity, it's particularly relevant because you risk to miss the tumor cavity. So I'm going to talk for a few minutes about how to avoid that. So, but before doing so, I want to talk, you heard before this concept of partial breast radiation. And the idea of partial breast radiation probably is a very good one, because it's the idea of reducing them. If you reduce the volume of radiotherapy, you can have fewer fractions, because somehow the late effects of radiotherapy are reduced if the volume is smaller. And you can, in fact, make it much more user-friendly, and patients can come just 5 or 10 times or 15 times instead of 30 times. So in this moment, there is a large prospective randomized trial that is comparing, is in the best way addressing the issue of whether giving partial breast radiation is equivalent to treat the entire breast, and the results are not out yet. There is at least another trial showing the effect of intraoperative radiotherapy, which is just one fraction at the time of surgery. It's very interesting because it shows some promising results. And then I'm going to talk to you for a minute about what we did, where, just a trial which was funded by the Department of Defense, where we gave prone partial breast radiotherapy, and we had quite good results. So, as Simon Powell had pointed out from Memorial Sloan Kettering, one of the challenges of, as I showed you before, this lack of definition and complexity of defining during the treatment where the cavity is and how it moves has made at least a third of the patients in this trial of the NSCBP, the partial breast radiation versus all breast radiation, excluded because they could not be randomized, because to make sure you will capture the tumor bed correctly, the seroma correctly, it became too big to satisfy the criteria of that study. So this issue of defining exactly where we go is very important. It becomes even more important, and I welcome you to discuss it later on, when the surgeon, in fact, does some kind of oncoplasty and obliterates that cavity. So then we cannot see the cavity anymore. So that's even more of a problem. We're clearly not eligible for this kind of studies. So I want to talk about this intraoperative, which is a way to give a very one fraction, kind of very user-friendly approach, but it's time-consuming, it's very much operator-consuming. This is the data from back home, Umberto Veronese, who introduced this approach in Europe. And the idea is that they put some lead against the chest wall to protect, scatter radiation from going into the chest wall, and then they put this radiation tube right directly on the tumor cavity at the time of surgical excision. So very user-friendly from the patient because it doesn't need to have radiation afterwards. The final results from this particular technique are not published yet, but Target, which was another approach very similar, has reported the results, and I'm going to show you in a minute. But I want to stress, look how the dose goes down fast. So as soon as you are at 1.5 cm, 15 millimeters from where the surface of surface of applicator is, you get practically very limited dose. So it's a very, very focused approach very limited to the cavity and a small margin around the cavity. And despite that, they were able to show that equivalence pretty much between the targeted intraoperative radiotherapy and a conventional 5 or 6 weeks regimen of radiotherapy in a large multi-institutional trial. And at least at a follow-up of 3 years, which is still early, they show no significant difference between the two approaches. Something to really consider, because in the United States it may be a little difficult because it takes an hour and a half of operating room to do this approach, and it's very competitive to use the operating room because you compete with other much more desirable procedures for the operating room. So surgeons tend to prefer to refer the patient to radiotherapy outside the operating room. But if there is opening and space for the operating room, certainly this is an approach that could be much more user-friendly for patients and should be considered. So instead, we explore, as I said before, the approach of putting women prone, the prone position, and exploiting the advantage of this position because the respiratory motion is much less, something that our colleagues in radiology have exploited forever, and for instance, MRIs are done in the prone position because you have much less chest wall movement artifact. So we exploited that, and we figured out a way to reposition the patient consistently, and I'm going to show you in a minute about that. And we performed a study where 100 women with very low risk of breast cancer were undergoing just 5 fractions of 6 gray each in this position, just to the tumor cavity, as I show here. And we just reported the 5-year local recurrence rate was 1%, which is quite competitive. And of course, enormous satisfaction from the patient and very good cosmetic results with this approach. And this is the cumulative survival for this trial. Then we study very carefully the movement, and we're able to show that with the approach we have, the movement is, with a cone beam CT, is very reproducible. And we're now training a lot of people to use the approach we have. We favor the external beam partial breast radiation because what's going on is that you can give it after you have obtained the pathology report. So they get surgery, you see which kind of tumor they have, whether they really need radiation just to the tumor bed or to the entire breast. And then you have like a total of 6 visits, while with the target, you have to commit the patient to this intraoperative treatment before the final pathology is studied, and there is an extra hour on anesthesia operating room time, which we feel is a big difference. But what I think it needs to be kept in mind is that very recently in JAMA there was a publication where by studying just a SEER report of users of partial breast radiation and risk of mastectomy for salvage of recurrence, demonstrated there was a higher mastectomy rate for these women who had brachytherapy for partial breast radiation. Brachytherapy is another approach to give partial breast radiation that I haven't described. And it seemed to be associated mainly to the fact that these patients were not in clinical trials, were treated just because it's very kind of appealing to the doctors and to the patient, and were not consented for the fact that we're not sure whether this is equivalent or not. So we have taken pretty strong positions over the years that only this kind of partial breast radiation needs to be done still as part of a research trial and cannot be done outside a trial. But, even the Society of Radiation Oncology has sent guidelines that allow for patients to be treated outside a trial. Now, I'll tell you why I think it's not a great idea to do it outside a trial. And this is a learning coming from different study where they look at women that were treated, in fact, to the entire breast. But they had a very nice homogeneous series of close to 2,000 women. Fox Chase and Gary Friedman reported their risk, just retrospective, but very homogeneously treated and so on, the risk of recurring in the same breast at the tumor cavity versus elsewhere. And when you look at this pattern, if you wait long enough, these are women that got irradiated to the entire breast. If you wait long enough, recurrences pop up outside the breast, but they pop up later outside the breast. So at the beginning, you see most of the tumor bed recurrences. and much fewer elsewhere recurrences. But over time, the elsewhere in the breast recurrences will happen, and this is the data for women who got the entire breast treated. It's likely that for women undergoing only partial breast radiation, you will see the pattern of the contralateral breast that goes up much faster, because there will be areas in the breast that didn't get any radiation, right? So there is a risk that at 15 years, you'll have a 15% or 20% risk of elsewhere recurrence after partial breast radiation. So we took the position that you need to consent women when you give partial breast radiation and make clear that it may be less effective in preventing recurrence of breast cancer than giving whole breast radiation. So, as I said, partial breast irradiation remains investigational, and whole breast radiotherapy remains the standard. Now, just a few words about whether we should give radiotherapy in the elderly, which is a big debate. Certainly in Europe, it's done much less. I feel it's a little bit, maybe because I'm becoming an elderly, it's much generous for a young doctor to say we shouldn't irradiate the elderly because the entire population is aging more. So, it's a big decision to deny an approach that reduces risk. And here I'm giving you, there is a very nice tool on the web called In Breast Tumor Recurrence that is like an automatic tool, a gadget where you can enter variables. Here, you have choices with a menu. So here I just enter older than 70, tumor size 1.1 to 2 centimeters, grade intermediate, margin status 0 to 2 millimeters is enough to have one close margin to get into this group, no lymphovascular invasion, no chemotherapy, and on tamoxifen or aromatase inhibitor. This is probably the epidemic, so-called epidemic of breast cancer, because mammography screening is going to see more and more of women in this group, and definitely is in the majority of patients we're going to see with breast cancer. And when you look at the fact in this subset, this seems to be quite benign. They start from a risk with radiotherapy of 1.6% of recurrence, and without radiotherapy, they go down to a risk of 5.3. They go up to a risk of 5.3% of recurrence. So this number and this kind of figure, I think, should be the choice of the patient. Until we have policies that restrict us to and somehow limits the use of this modality, I think the patient should be offered this option, and at least the 70 years old I meet are often much younger than their 70s, and the majority of them will choose to undergo the treatment. So it becomes our responsibility to give a treatment that is user-friendly and is economically sound. So certainly don't want to spend more money if we can avoid to. And, this is also in Europe. What's going on is the target elderly, which again is trying to compare giving whole breast radiotherapy to intraoperative radiotherapy to these patients, and definitely is focused on treating women more than 70 years old. For them, it's research, because in this moment, most European countries will not offer radiotherapy in women undergoing partial breast cancer conservation who are older than 70. So I want to talk about cost for a minute. So if you use the very common mammocyte approach, which is in form of brachytherapy, or high-dose brachytherapy, high-dose rate brachytherapy, this is a kind of cost in dollars of the procedure. If you use partial breast radiotherapy with IMRT, which is a form of radiotherapy, this is a cost. The way we could reduce it in terms, and this is both the cost of using the machine and the doctors and the planning and the physicists and so on, by using partial breast radiotherapy in the prone position, is to go down to $4,700. Is it low enough? Probably not. I think there is room to make it less costly. And definitely, while completely against the interest of my discipline, I think this procedure should cost less. But it's going to be a big ethical decision to decide whether we're going to, somebody's turning 71 is not going to have it, but she was 69, she was going to have it. So I definitely believe that until there are different policies, the patient should really be given the choice. And again, I want to stress this is just 5 fractions, so it's 5 visits to the radiation center. So I'm just going to talk about more technical things about why we address this issue of movement and went prone and went with women lying on their stomach. And this came from an important study from Sarah Darby, where she was able to compare in a very large database of 300,000 women the late effects. So she followed these women for many, many years through the SEER registry, and she did something very, very smart. She compared women who got everybody had breast cancer. She compared women who got radiotherapy to the left breast to women who got radiotherapy to the right breast. And that was an interesting trick from a study design point of view, because what's going on is that when you treat the left, imagine the feet are up here and the head is back there, so this is a cross-cut with the left breast. It's cut off here, but the heart is here. This is lung, chest. The left, when you treat on the left breast cancer, since the breast wraps around the chest wall, the LAD, which is this very important coronary artery, is often included in the field when you're treating supine. And if you treat the right, is not. So this is a built-in control for all the other variables, but you're getting to sort out the impact of irradiating part of the heart and this important coronary artery. And in fact, she showed that on the average, 58% more risk of cardiac mortality at 10 to 14 years. So the risk stays for life, but she was able to report it at 10 to 14 years. So I think it's a huge responsibility to expose women to this risk, when in theory they could have had a mastectomy with very much kind of optimal reconstruction, as you've seen before from the pictures that were shown by the previous speaker, and without informing them that they could have this risk in terms of increasing their mortality or something else. So we took it very, very seriously and made it very much for the past 10, 15 years the center of our research. Interestingly enough, she also showed more risk in ipsilateral lung cancer, suggesting that excluding the lung from the radiation field is as important. So a modality that will reduce the exposure of heart and lung is of the essence. So others, this is my friend Frank Vicini, that he was really a pioneer on this, and they have a complex way where they train women to breathe in and out and exclude the heart and the lung, and if done right, it really does work. I can tell you I could never get my patients in New York to really undergo every treatment, this kind of entire apparatus and entire training, so it was not practical, at least in our hands. But as you can see, if it's done right, the heart flips out, a little bit less of the lung. But by modifying, training the patients to hold the breath using radiotherapy, you can, in fact, avoid the heart and the lung. And there are other techniques. But what we did from the very early on was to flip the woman, and put her on her stomach, and avoid the inclusion of the heart by doing so, and avoiding particularly the inclusion of the lung. And here is an example. So there you can see the two versions. So the important things once you introduce a new approach is to assure that it's reproducible, and also that you not just at your center, it can be done by others, and many others now are doing it. So one approach is to make sure that you, at the very beginning, you get a cross-cut of the patient, and you can see all these little dots, define a plane, and that becomes a plane of reference to plan the patients and to design the treatment fields based on that. And we put marks on the patient that make it possible to reposition her every day in the same position. And here is what happens. This is a patient on her back and on her stomach. You can see the difference. When she's on her back, you have the heart in the field, and when she's in her stomach, you can avoid it. And, we have published to show that it's reproducible, and we have several prospective studies, and some of them, this is randomized studies, that address this issue. And I'm going to move a little fast on this and just give you the juice of this, which is in the study where we consented women to undergo 2 CT scans. So these are very generous women who accepted to be imaged on a CT scan on their back and on their stomach. So for each patient, we had a comparison built in, 200 on the left, 200 on the right, of how much tissue was going to be in the field when they were lying on their stomach and on their back. We were able to show that, in fact, the infield volume, both of the lung and the heart, correlates with those, which was intuitive, but we were not sure until we measured it, and we reported that. And then, here you can see, particularly for women who have a large breast, is very obvious. When they go on their stomach, you can avoid completely both heart and lung, while you cannot when they are on their back. Here's another example. And we demonstrated that in 85% of the left breast cancer, in all the right breast cancer, if the target was the breast, the prone setup was better. And we just reported this data in JAMA. And I just want to show you that this is how to assure that the breast is included. So in both positions, so the same target is maintained. So it's in front of the latissimus dorsi in both positions, and on the edge of the sternum in both positions. So what we do in this moment is that we set up everybody on their stomach, and only if there is some heart on the prone position, we set them up also on their back, and then we choose which one of the two best avoid the heart. And if it is on the right, all of them are better off in terms of avoiding the lung, so generally we never have to reposition them on their back. So people have said, okay, this is nice, you avoid the heart and lung, does it work? So we are now completing a manuscript, it's going to be soon submitted, on 490 patients who were all treated on their stomach. They all were treated with this hypofractionated regimen of 3 weeks, where we're treating the entire breast and we're giving a concomitant boost, so an extra dose to the tumor cavity. And this is our local recurrence at 5 years. Now it's corrected at 5 years is 1.2% in breast recurrence, so quite good for the population we're studying. This is the 5-year actual local recurrence-free survival. So we showed recently that, in fact, it's not necessary to use intensely modulated radiotherapy, which is a prettier and more efficient, in terms of dose distribution, a more accurate tool to give a very personalized dose and tailored dose on the shape of the patient. But with 3D conformal, we show that in terms of cosmetic and late effect of the patient was equivalent. So definitely it can also be done with a cheaper and easier approach. And we have a prospective randomized trial where we're trying to compare to give the concomitant boost versus once a week boost. And so far, just going to move a little fast on this, in terms of acute effects are exactly equivalent, and we don't see any difference. So far we've done more with this prone approach. More than 1,300 patients were accrued. We didn't see any grade 3 or 4 toxicity, so we continue in that path. But in a critical way too, because we cannot just say the prone is better without covering also the times when it's not. And it clearly depends on the target. So as you have heard before, if they're going to do less surgery in the axilla, if the practice is changing, as was described so well before, is radiotherapy prone going to be as good as radiotherapy supine in covering the axilla? And it's difficult because, as was pointed out, they haven't really reported how well radiotherapy play into the results and the definition of the dose and the fields in this cohort of patients of the randomized trial that Giuliano reported recently. So, when we did a study in 2008 where we were able to show that already when you're treating supine, you're missing much of the level 1, 2, and 3 nodes. You cover some, but some is out. But you're even sparing it more when you're using prone position. So it may be possible that prone position is dangerous if you don't want, if you leave behind the level 1 and 2 lymph nodes. So it's a concern we are very clear about, and we develop a technique for adding, assuring that if your target is the axilla and the supraclavicular nodes, you can do it prone. And this is actually published in Radiotherapy or Oncology. So I want to conclude by saying that Dr. Berry from MD Anderson did, several years ago, did a nice projection of the progress, some kind of modeled the progress we have made in the past. He did it 7 years ago, so in the previous 10 years. But I think it's sustained, and other groups have demonstrated, in fact, that it's still very close, is a 1% decrease in breast cancer mortality per year with all this investment in research and effort in breast cancer. And half of it most probably comes from early detection and derived by widespread screening, and half from treatment. More and more we tend to believe that is probably 1/4 from early detection and screening and maybe 3/4 from treatment. But while it seems like a very small progress, 1% per year, I wish we could say the same for many other cancers, and definitely we're going in the right direction. So hopefully soon will be a chronic disease or certainly a disease that doesn't kill anymore. So I'll stop here and just acknowledge the group that worked with me, particularly the physicists who really played a big role in the prone radiotherapy approach, our nurse practitioners and the data managers who are great, and my colleagues, Dr. Limberson, Dr. Huppert, and Judy Goldberg, who's a statistician, and of course the therapists, who are the people who give the radiation treatment every day, that we really are responsible for the quality of what we're doing, and our patients who participate in these trials. So I'll stop here.
That was an excellent talk. I have a question, something that comes up quite a bit, and sort of the order of the speakers, chemotherapy first, and then surgery. What to do with radiation for a woman who's had a mastectomy after neoadjuvant chemotherapy? There's not a lot of randomized evidence on it, so I was wondering what your practice was.
So we do give radiotherapy post-neoadjuvant chemotherapy even after a mastectomy. And at least the practice at NYU is that we tend to irradiate women after they have an expander as part of the reconstruction before the final implant is put in place. But I'm very aware that there are other approaches where they put the final implant and they give radiotherapy after the final implant. I don't know of any study that compared the two approaches prospectively in a randomized. I don't think it's realistic to imagine that there will be a study in that direction. But I suggest that it's very difficult to deny radiotherapy to these patients, and probably the subset that are less likely to benefit, but there is controversy, at least in the radiotherapy field, are the women who got into a pathologic complete remission. So those women, they have no residual disease. They started with large tumors in the breast or even with sizable tumors in the breast. They have nothing left. And in those patients is a long discussion, but I show the post-mastectomy data with the radiotherapy, and while their sequence is different because they got chemo first and then surgery and then radiotherapy, I presented the data, and it's not that simple. There is data suggesting the chemotherapy, even in women with complete remissions, there is, at least in T3 tumors, there is data suggesting that down the line, the risk of recurring without radiotherapy is very small. So probably they do have the options not to have a radiotherapy. In those women, particularly if they have negative nodes, I will not irradiate the axilla, but I may irradiate the chest wall.
I'll add another question. You mentioned keeping the heart out of the field with prone positioning, and we know from our dose histograms that there's fall-off. You put up a slide that showed the correlation between radiation dose and the distance from the field, or the location with the field, and also, respiratory gain and prone both achieve the effect of the heart when both are done appropriately. Is there a dose to the heart that you try to stay below? Is there a safe dose?
So we have a collaboration. For years before doing prone radiotherapy, I was trying to block the heart after 30 gray, right? So I'm putting blocks. But if you put blocks in the supine position, you're going to miss part of the breast. Now with IMRT, you can do it better, but there is a complexity in that too. We have now a collaboration going on with cardiologists who train me that, in fact, using even the mean LAD, which is that coronary artery I showed you, the mean dose to the LAD may be misleading, because in the universe of cardiovascular disease, it doesn't really matter how you spread, the toxicity. It's enough to clog one spot of the LAD. So if you have the LAD in the field, getting 100% of the dose, just in 2 or 3 millimeters is bad enough. So it may be, what I think is crucial is to exclude it. And the moment, you're absolutely right, the moment it is outside the field, is not zero, but it's at least 50%, because the 50% isodose line is on the edge. So if you're lucky, it's getting 30, 40%. Clearly, if it is in the field, it's getting 100%. So I think being very cautious to keep it into the 30, 40% is probably good enough, and keeping in mind that, particularly in the aging population, they already have predisposing factors to cardiovascular disease, so you're building on top of it. Thank you.